I'm going to talk about transradial access for endovascular therapy of a critical limb ischemia. I have no disclosures. So the radial access is currently being used frequently in left heart catheterization because it has shown to decrease the incidence of vascular complications. In this case, we are describing the use of radial access in peripheral angioplasty. Our case is a 52-year-old smoker female patient with past medical history of hypertension, hyperlipidemia, diabetes, and history of severe PAD with totally occluded infrarenal abdominal aorta just distal to the renal arteries and known right axillary femoral bypass and fem-fem bypass. She presented with bilateral leg and foot pain at rest, diminished pulses, and ulceration of the legs. Her ABIs were abnormal. The right leg ABI was 0.27, TBI 0.12, left leg ABI 0.3, and TBI 0.12. Rutherford classification was 6 by definition. The CTA showed total occlusion of the axillofemoral and fem-fem bypass with totaled infrarenal abdominal aorta with reconstitution of peripheral circulation at the level of the external iliac arteries bilaterally. So these findings confirmed by angiogram obtained by accessing the radial artery, as we see here in these images. Our procedure was using the radial access in conjunction with ultrasound-guided access to the right and left common femoral arteries with successful PTA and stent to the abdominal aorta using self-expandable stent, and to the right and left common iliac arteries using covered stent in a kissing fashion. So here's the conclusion, where we had successful PTA and stents to the aorta and bilateral iliac arteries. On 3 weeks follow-up, the patient's symptoms of claudication has resolved. She had good pulses bilaterally and favorable ABIs. The right leg ABI was 0.84 and TBI 0.68, and the left leg ABI was 0.82 and TBI 0.65. Our rationale in using the transradial access is that the transradial access seems to be safer and preferred over the brachial access due to the complications associated with the brachial access. The brachial artery is usually avoided because it is an end artery, and its iatrogenic occlusion by local dissection or thrombosis can lead to limb ischemia of the forearm. Also, it is situated close to relevant neural structure, and so palsy is dreaded complication. Finally, the fascia of the upper arm is tight, so bleeding episode can lead to severe compartment syndrome requiring immediate surgery. Advantages of the radial access for PAD intervention include decrease in access site complications, more rapid ambulation, same-day discharge, and increased patient comfort. There are relative contraindications to the radial access, which include absent pulse, an abnormal Allen's test, Raynaud's disease, the need for dialysis shunt, and functioning shunts. So in summary, transradial access for PAD interventions seems to be feasible and promising technique with lower procedure complication rate, which make this approach preferred over the brachial access. Thank you.